So today we'll be learning how palliative care is practiced. My question to Dr. Dam is how can we practice palliative care? Can you tell us the various modalities?
Well, palliative care, how do you actually practice it? The best place, so let me counter you with a question. Given a choice, where would you like to die?
Certainly my home.
So the answer is very simple. Nobody wants to die in a hospital. Everybody wants to die at home, provided they have somebody to take care of them at home. So palliative care is basically directed to improve the quality of life of the terminally ill and the dying patients. So the best place for starting palliative care is in the home of the patient. So once you go down to the house of a patient and see how he lives, where he lives, what are his social conditions, what is his financial status, and only by understanding him and his family and his surroundings can you actually prescribe the best treatment plans for him. Just by seeing the patient in your own clinic, the patient comes to your clinic wearing a mask. A mask means his features, he comes dressed up, he combs his hair, he comes applying perfume, he wears his best shirt. So that is not him actually. He is dressed up for you, he is come as an actor. But if you go down to the home of the patient, what you see is his true nature. And only if you understand his true nature, what are his needs, what are his sorrows, what makes him laugh, what makes him cry, can you do the best justice for him. So home care remains the backbone of good palliative care. And then comes what we call a hospice. A hospice is something between a home and a hospital, where there is a lot of flexibility and the patients can come in and stay in a hospice for short durations of time, so that there is respite care, or when the symptoms become too severe, the patient can come and have a short period of rest in a hospice and again go back. The third place are the nursing homes, which are private. So you can keep the patient in a nursing home for short periods of time. It turns out to be quite expensive. And then there are the hospitals, large hospitals. But again, getting admission into a hospital just for a palliative intent of care is again difficult, because hospitals are always busy, beds are in shortage. And of course, the government of India, through its various state programs, are now trying to designate certain beds in all hospitals for just for palliative intent of care. So right from the home front to hospices to nursing homes and hospitals, and there is something in between called daycare also, where you just take care of the patient just for the day, and the evening the patient goes back home. So these are the varied spectrum by which palliative care can actually be administered to the people.
Thank you, Dr. Dam. And Mr. Menon, can you throw light on caregivers? I've been listening about this word. What exactly do you mean by caregiver?
Caregiver. It's a very beautiful term, but it contains a lot of difficulties, stress, and strain and all that. All negative. This thing is there. A care. You know what is care? Giver. He is giving the care. Actually, we make it in a different way. We say bystanders in a way. Bystanders means those who are standing by the side of the patient who needs care. So these bystanders may be usually a member in the family who may be having no other job, especially. So those who are having a job, they will have to go to their office or wherever the workplace and all that. He or she may not be able to do justice to the caring of the patient who is already in the house. So usually, suppose if a male member is getting an irreversible disease, the female members or the wives who may be housewives will take the job of the carers. That's what we usually do, because she will have to take care of the patient who is her husband, to take care of the children, their daily routines, their education, and make out something for their food, the kitchen activities, to get some money for the survival of all the members of the family. So these caregivers are having a lot of services, a lot of thinking, lot of planning is required in the case of a caregiver at home. That's what I would like to explain in a briefest manner. There are a lot of other ingredients and components that are to form part of the term caregiver, and our presentations are clearly mentioning the detailed what type of caregivers are there, what are the functions of the caregivers, what are the stress or burnout of the caregivers, and a lot of things connected with the caring of the patient who is already in their own homes.
To sum up, caregiver may not be the person who is charging you and giving the services such as doctor, nurse, or any attendant, but the family members, the neighbors, the community people can also be the caregivers to the chronically ill patients. So doing this course, you can become a caregiver not only to your family, to your neighborhood, to your community, and that is what we are aiming at.
A trained caregiver, I may call it.
Yeah, great. So, Dr. Dam, would you throw light on the multidisciplinary team?
Yeah, because you see, palliative care is it's very difficult to deliver palliative care just by yourself. You cannot always be a jack of all trades. So it's basically a team approach, right? You need to go in a team, and every member of the team is important. There could be a doctor, there could be a nurse, a social worker, a volunteer, a person who knows the patient per se, somebody from the local community. All these people have various roles to play at various points of time, and even a religious leader or a cleric for that matter. So all of these people play different roles at different points of time, or maybe they all integrate their skills in providing and help to improve the quality of life of the patient. So every role member, every person is important, and it's a team approach.
Thank you, Dr. Dam. So basically, we have learnt about the various aspects, and we would like to sum up this session. Thank you. Have a great day.